etiological factors you find in CSF anemia, sir?
Sometimes we are seeing that patients come with hypertension also. Hypertension, then long-standing acute infection of the nose, and sometimes infected cases, they come with pulposis and all these things. And also one case I got history of trauma was there. Old history of road traffic accident. So that also came to my chamber, and I didn't know this case. Anything else happened, and then MRI was done, and exact was done. And then the subsequent intervention.
Dr. Sharia, in your cases, what were the etiological factors and which one is the commonest one you find?
Thank you, sir. In our cases, previously we know the more common other issues. So recent they say the trauma. Basically, the iatrogenic trauma. That is the main causes now. In our most of our cases, we found that here the history of trauma, road traffic accident, or anything, or the iatrogenic cases during cerebral malignancy surgery or any other surgery. Most of the cases we found that.
Dr. Deepankar wants to add something.
Causes are divided into two: traumatic may be iatrogenic or accidental. Iatrogenic during surgery, accidental road traffic accident, usually mainly blunt trauma. And others are congenital, some are inflammatory polyposis, and other fungal sinusitis, and some congenital may be mainly traumatic, and some are idiopathic.
Actually, I am asking about your experience. Dr. Wahid, what is your experience?
My experience is 90% also idiopathic, sir.
Okay.
As sinus is developing, is academic student right? But academic our department, we find 90% is idiopathic.
Okay, so it may be idiopathic.
Other cause also that is congenital meningitis.
Yes. Maybe non-surgical trauma, maybe surgical trauma, as Dr. Saurabh has said, intranasal surgery.
Babu sir, I want to include one thing that in some instances the patient present with the concomitant complaints of the chronic bronchitis or chronic cough, there is history of constipation or like that. These associated features are also present in the affected persons. And some professional cases also, the weight lifters, in defense the boxers, those who practice the boxing, these sort of people also having they also kind of need the diagnosis.
And these are the aggravating factors. These factors prevents healing of the leak. Okay, thank you, sir. So for diagnosis, sir, Ashraf sir, for diagnosis, what workup you want to do, sir?
Yes, before that, on the causes,
Sir.
in my practice,
Sir.
I have seen the traumatic cases.
Trauma.
Because many of the traumatic cases, they remain undiagnosed. In many peripheral centers, they are treated, but after that, they go home and develop this. And this is one of the reasons. Definitely, that is next on is the spontaneous. Iatrogenic, nowadays, iatrogenic has reduced the number because of the massive training of the ENT surgeons, expertise of the surgeons. That's why it has. Earlier days, that was the main factor of iatrogenic. Today, it is reduced a lot.
Dropping down.
Yes. That is the training of the ENT surgeons doing the endoscopic sinus surgery or functional endoscopic sinus surgery. Another cause is aggravating factor nowadays is the obstructive sleep apnea. That is the most rising cause of the CSF Rhinorrhoea in spontaneous cases. The other factors is the female obesity. So these are coming up. And I have got two cases. That is the obesity and obstructive sleep apnea. The third factor, the recent past, is the during the personation or child bearing age and after on the delivery. that is tremendous and that is obvious in the spontaneous case. These are the three factors coming up with this new technological development. Now, in the diagnosis, the definitive diagnosis and the sequential diagnosis. The definitive diagnosis of the two factors, here is the whether it is the CSF or not, and the site of the location. Whether it is the CSF or not, that is the specific and accurate diagnosis by the beta task finder. That is the specificity, the highest specificity, and but beta transferrin test cannot give the location of the or site of the leak. The site of the leak is to be diagnosed by routine procedure with the diagnostic endoscopy, and this diagnostic endoscopy, as you have already mentioned, that is the reservoir site, and with the valsal valve and the quickness advert test. That is you block down the two internal jugular vein and the rising of the pressure, that if there is any CSF in between in that cranial cavity, that comes down. That is the diagnostic endoscopy. The third is the interventional is CT cystonogram. The CT cystonogram has a limitation, but today is the MRI cystonogram. I have shown many of the cases to you in my medical college. The CT cystonogram, MRI cystonogram. That MRI cystonogram T2 weighted image that gives the CSF and the other leakage, the fluid, more concentrated, and that is the most diagnostic and the hallmark. So the hallmark of the test is one is beta transferrin and the other is MR cystonogram. There are so many tests.
Okay.
But these are
So, Colonel Tohid, what workup, when the patient comes to you, you let her water in nasal picture. What workup you will
So
do?
thank you very much, sir, for a very nice question. Before giving answer to this question, I want to add something for our young stars. What we do, why we do the beta transferrin. Beta transferrin is not available in Bangladesh now. I've seen it is done in India in some specialist center. Our Indian colleagues are there, and in Singapore and in the advanced part of the world. But beta transferrin is a very pertinent part of the CSF, and it is available in the CSF, the perileaf, and the aqueous humor of the eye. So it is very specific. If we can diagnose it, we can confirm that it is CSF. And the workup, about the workup of the patient, the very presentation of the patient, the very history of the patient will lead to the diagnosis of the CSF rhinorrhoea.
Actually, what may be the presenting features other than grouping of pictures?
There will be the nasal, along with the nasal discharge, patient will
Others, what may be the other symptom?
Other symptoms might be the history of trauma or the history of constipation. Patient might be a smoker and chronic bronchitis or emphysema, or chronic cough patient. Patient might have the history of the constipation, or patient having the obesity.
Actually, these are the aggravating factors or the factors which prevents healing. Can there be any Ashok sir?
actually the diagnosis starts from the history. The history of the patient is to be solved very accurately. The associated symptoms, the clear unilateral watery discharge, number one, associated with the headache,
Yes.
so that, and then anosmia or vomiting. This is like the meningitis, symptoms of meningitis.
Yes.
But that is the inapparent, not that is the apparent symptoms. Patient does not develop any meningitis apparently, but the patient behaves like the symptoms of meningitis. That is the most important factor in the diagnosis of CSF rhinorrhoea. Many of the patients, they say, I don't have any meningitis, that is the nuchal rigidity or like that, but the symptoms appears like that. The third factor,
And headache, neck pain.
yes,
Sometimes maybe there may be blurring of vision as well.
then the third factor is the orbital symptoms.
Yes, sir.
That is orbital symptoms, is the haziness of the eye or the blindness here. Because these are the factors remaining in the history taking of the patient. So meticulous history is important, which reveal the diagnosis of the CSF rhinorrhoea.
Okay, sir. Dr. White, please.
Thank you, sir. Ashok sir said everything. I have to add something. There is headache, about headache. Headache actually subsides after dropping some CSF, usually. When patient subsides. Is there important history? মানে after dropping some CSF fluid from the nose, patient complains headache.
Reduced headache. Okay. And is there any cough symptom of cough? Can it be?
Yeah. They can be I will just illustrate one practical case which I used to see in my OPD. One lady was there around 45 years. She used to come with recurrent unilateral discharge, clear fluid. So I thought it was CSF Rhinorrhoea, so I was diagnosed also. But after giving, say, Diamox, she was cured in 1 month. And then again, after 6 months, she again came with a repeated problem. Then she had recurrent upper respiratory infection, fever, headache, all these things. So I think these systems are very, very important.
Okay.
They aggravate the CSF.
Yes, sir.
And until now she is okay, and whenever she has this recurrent URTA fever, she again comes with this.
Sometimes there is drooping of nasal fluid and to the anterior nares, and sometimes goes into pharynx and patient irritation and cough. So we think that she has, maybe she has some obstructive respiratory tract infection or like that, but it is due to CSF leak. And you repair the CSF leak and cough will stop. You give many anti-cough or COPD treatment, but the patient does not improve in that cases. So, pathophysiology of cough is the fluid goes into the pharynx, irritates the pharynx or larynx, and patient coughs, particularly in lying position. And lying position and sleeping, the patient says, I cannot sleep through the whole night. And when you give the conservative treatment, CSF leak drops and patient improves. But you give any COPD treatment, many things, but she does not improve. So it may be one type of presentation. So clinical features, laboratory tests.
Can I answer Colonel Bashir's?
Yes, sir. Please, sir.
Actually, cough, it is present with the reservoir side. The brain acts as a ball valve. In any case of CSF, this is the pathophysiology. Pathophysiology is the ball valve effect of the brain. When it lies down, when you are asleep, the brain goes posterior, and the neural effect, the herniation becomes over. Whether it is spontaneous or traumatic or whatever the leak present. So it remains open, and the fluid comes down and remains in the, either I told you earlier that whether it may present in the sinus cavities or in the nasal cavity, that trickles down in the pharynx posteriorly. That is the postnasal drip. The patient develops postnasal drip invariably in lying down condition. That incites the coughing mechanism.
Thank you, sir. Sir, we do laboratory test. Beta-2 transferrin is the almost definitive, not 100%, even though not 100%, but that is the best test, laboratory test. Is there any other test we can do in Bangladesh, because here there is no test?
We usually do the CT systemograph.
No, laboratory test.
Laboratory test.
Biochemical test.
We can do the actually to differentiate between the whether it is CSF or the nasal secretion. So we can do for the CSF study. So CSF trial study. In that case, in case of the nasal secretion, usually it is associated with allergy, so there will be more count of eosinophil, cell count will be more, the protein will be more.
Glucose, anything about glucose?
The glucose will be more in case of the allergic condition or inflammatory condition, but in case of the CSF will be less.
Dr. Deepankar want to add something. Okay, as because of shortage of time, Dr. Deepankar has said about 1/3 to 1/2 of the blood sugar level, sugar level in the CSF. So this is one of suggestive that it may be CSF leak. Okay, then nasal endoscopy, sir has added, please sir.
In the glucose test, very routine. For the juniors, I will just send a message to them. For the glucose test, very simple is the fluid is taken, the tip is taken. Just the glucose, the diabetes metabolic is tip. That glucose tip gives you the idea that is the CSF. Yes, there is a quantitative test. That is the quantitative. If it goes 30, more than 30, or above, there is 30, then it is definitive of CSF.
At the same
You
time,
know,
sir, at the same time we can do blood sugar.
you can correlate. That is correlated with the last second and the last one. So these are the three one. The correlation of this CSF with the glucose. One is the CSF, and the first that is the CSF and the blood. So if they correlate to the three in the same way, then definitely it is a definitive test. But it is not the specific test again, sir. Yes, sir.
Sir, nasoendoscopy, you have added that preoperative nasoendoscopy. We can do nasoendoscopy. Sometimes we can see the water is discharge, and sometimes even we can see the site of leakage as well, particularly if it is in the fibrillar plate. And if it is coming from the middle meatus, it may be roof of the maybe phobia, maybe other thing. It comes from the comes from the sphenoidal recess, it may be from the sphenoid. So by this way you can test pre-operative nasoendoscopy. And operatively also we can confirm the site of leakage. Okay. So imaging. Sir has said about CT and MR system. Dr. Wahid, if I ask, my patient asks, sir, what imaging should I do? There are today's patients are learning from internet. Patients comes after reading many things from internet. Patient asks, sir, I have found that this imaging can be done. What imaging you suggest me?
We suggest usually HICT or PNS with skull base. Usually we suggest 0.5 millimeter, especially coronary tube. Both axial size are also needed.
Is there any role of bone window?
Yes, often bone window.
Bone window. Okay.
Bone window scan to be
The first of all, you want to do CT scan.
Yes,
Why not CT cystogram or MR cystogram first?
It is cystogram is actually an invasive procedure. It has so many complication. So first of all, we have to do HICT or establish and PNS.
Okay. How common you can find the findings, positive findings in CT?
We find positive near about 100%.
Okay. So this depends upon the who is reading the CT and how much he is the trained in reading the CT. I want to mention one thing. There are two patients admitted here for operation. One yesterday we have done surgery. There are reading of CT reports are there by general radiologist, not the skull-based radiologist. It does not correlate with our findings and does not correlate with our findings, our readings and our findings peroperatively. So we must know how to read CT. We must know how to advise CT. আমি বলে দিলাম যে সিটি স্ক্যান করে চলে আসেন, সিটি স্ক্যান তো হবে না। Dr. Wahid mentioned 1 to 2 millimeter, maybe 0.5 to 1 millimeter. Contiguous sections, no gap, contiguous sections with bone window. And we find that more than 90, even 95, 96, even some centers says more than that, we can get the positive findings there. So whenever a patient comes, we don't want to jump to any advanced investigations. And Dr. Saurabh, if CT scan fails to show any positive findings, what next investigation you want to do?
Then we can do MRI and T2 and
Fat suppression. Yes. Okay, fine. And literature says CT scan and in failure cases MRI. In combination of two can diagnose almost 100% cases. So what is the conclusion? Conclusion is cysternography should be advised last if we fail to diagnose by these two. And almost 100% cases can be diagnosed by CT, and in some cases by we can take help of MRI T2 weighted with fat suppression. Dr. Nuralam, I want to add anything? MRI, yes. Yes, we are coming to benign intracranial. Yes. Yes. We are coming. We are coming to that point next. Okay. Sir, endoscopy. Can we do auto endoscopy? Should we do auto endoscopy, sir?
Yes. In my experience, one of my patients, those are from the librarian, some daughter of the librarian. The patient comes with autoria, but tympanic membrane is absolutely okay. It is coming from the external auditory. So another case I found in the nasopharynx, that is the only coughing, post-nasal drip. So in this particular cases, the autoendoscopy is a must. This autoendoscope gives you the idea at the location of the site, that is the lip, site of the lip, but not the site from the actual dural herniation. It can see only the coming out portion, that is the fistulas, outer fistulas part, but not the inner fistula. So autoendoscopy can give you the guide, one, either from the tympanic membrane or the external auditory.
Okay, Dr. Deepankar, what is otorhinorrhea? Otorhinorrhea. CSF otorhinorrhea.
Patient come to us with CSF rhinorrhea. By through investigation, CT, MRI, we cannot find any leakage site in user site. Then we advise to do CT of the temporal bone. It may come from there of the fracture of the temporal bone and CSF autoria, and from there comes to through eustachian tube in the nasopharynx, then in the nose.
Okay. So it is called otorhinorrhea. CSF otorhinorrhea. Sometimes there is no leak in the anterior skull base. Nothing is found. So we have to do, although it is not very common, we routinely can do, should do the auto endoscopy. And in some, we don't want to miss any cases. So thank you. Sir, okay. So it is a result of meta-analysis. From CT scan up to 84%. It is a old meta-analysis report. MRI up to 100% can be diagnosed. And when we fail to diagnose by CT or MRI, some cysternography, CT or MRI cysternography may be done. Technetium 99, this is an old test. Nasoendoscopy, preoperative, peroperative, and addition of sodium fluorescent. When it is indicated, Dr. Shuro?
Fluorescent dye, it is indicated in the, if we inject the dye peroperatively, then we can see the fluorescent dye with the endoscope. And also it is necessary after repair. If our leak is, after repair of the post-operative, if there is leak or present or not, it will be helpful in fluorescent dye.
But for detection of leakage site, is it very commonly
Absolutely,
recurred?
yes.
Is it very commonly recurred?
No, sir.
When we cannot find any leakage.
Yes, sir. Then only we can do fluorescent dye.
Sir, Dr. Ashraf sir want to add something. Please, sir.
I have not done first,
Sir.
but I have seen during my training in Australia, Physio Award
Sir.
is my guru in the sense of the endoscopic sinus surgery. Routinely he does, in every cases, he does interthecal fluorescence.
He used to do, sir.
He does it.
Nowadays as well.
Because why? I asked him. There are so many contradictions. There are so many, failures or complications. So why he does? Because peroperatively he dilutes 0.5 ml fluorescence with 10 ml CSF. 10 ml CSF. Then inject, and blue light filter is a very developed area. There is a blue light filter. He just locates power per table. And after the operation, he again says there is no leak. That is, he says this is the watertight shape. That is, he says this is the watertight shape. And in his book, he has also mentioned that is the intrathecal fluorescence. But other than this, I have seen another case in the Hyderabad. He does it. So intrathecal fluorescence is a choice of many of the other surgeons.
Okay. In many surgeons practices routinely. Sir,
Fluorescence dye may be helpful in the multiple
leakage
also.
to diagnose.
But I agree with sir, because we don't use it invariably, but one of our neurosurgeon colleagues, they use it invariably in Bangladesh also. Sir.
Okay. So Dr. Wahid, do you ever use sodium fluorescent? So what is your experience? Without doing sodium fluorescent, what is your result?
We don't have any experiment using sodium fluorescent dye. We don't need actually.
I know you do many CSF leakage repair in your center. So you never used sodium fluorescent. So what is your result?
My results are, I have already 48 pieces, only one failed by experience. And I, till now, I used sodium fluorescent dye.
You never used sodium fluorescent dye. So your result is very good. So many surgeon has many experiences, many practices. So we have to know the different opinions, and we have to choose my opinion, what will I practice. So what may be the contraindications or complications of use of sodium fluorescent?
First of all, sodium fluorescent dye is causes seizure.
May cause,
May cause seizure.
not always.
Just contraindication maybe it can be used in pregnancy, it can prevent failure of position and abnormality. That should have some allergy. It is there which may cause
Okay. So there are some contraindications, there are some complications, but in where I cannot find any leakage site during surgery, in that case I can use. But some surgeons do practice it regularly, as our professor, respected sir is saying, Professor Ashok sir has said. Thank you. Nasal endoscopy. Sir, after seeing the defect in the MRI, you see here two cases up there. Collection in sphenoid sinus. You can see collection in sphenoid sinus. So, is CT or MRI is always definitive? Dr. Wahid? Is CT or MRI or image finding is always definitive, or you have to conclude by something else?
Sir, according to me, sir, CT finding is always definitive.
Okay.
And if I suspect any meningocele or internal cell, so I can add MRI. But in case of MRI, when positive finding, you will get on active leakage. MRI.
Dr. Dipankar.
In case of CT, one will find any opacity near the sinus narrowness cavity. That at that time we can advise for MRI. Okay, it may be meningocele, it may be an
Okay, thank you. Here I present one example that the MRI findings shows the collection in the sphenoid sinus, right sphenoid sinus. But when I have done endoscopy, I found something which I was surprised to see, and the endoscopy finding is not very clear, but you see the fluid is flowing through the anterior wall of the sphenoid and enters into the sphenoid. But the leakage site is another, iliac-uniform plate. Fluid is coming from the uniform plate, flows over the anterior face of the sphenoid and enters the sphenoid sinus. So this is not always the fact, but it may happen. So the confirmatory site is during surgery or preoperatively the endoscopic finding. Actually, from where the fluid is coming, fluid may come from may be collected in another phase and another place, another sinus, and we see it in the image. So CT scan plus minus MRI with or without cysternography and endoscopy. Endoscopy is the final decision. Correlation of everything. So, preoperative, it is a study. Preoperative nasal endoscopy can give 36% accuracy. Up to 36% accuracy may be given. But paraoperative endoscopy will give the definitive answer. Management. Sir, Dr. Shurov, sometimes we give conservative management and sometimes surgical management. When you will suggest conservative management?
Thank you, sir. We suggest conservative management actually by the trauma. It may be trophic accident or iatrogenic trauma. And in my experience, I also found some of cases where do septoplasty or SMR surgery. After that, CSF leak, that surgeon gets CSF leak, then referred to our center. Then only conservative management can heal the CSF leak.
Very good. And if there is short history?
Yes, sir, short history.
Short history of not only the rotary, but short history.
Short history, yes.
That is conservative.
Excellent.
Professor Dr. Wahid, what conservative treatment you will advise?
I want to add something, sir. In the case of trauma, we have to examine CT scan. If any fragment drop across and drawing causes apart, then you have to go through surgical treatment.
Okay, to remove the body spicules. Only in that case you can go for surgery. Okay, thank you. So, what conservative treatment you give in your cases?
Sir, first of all, bed rest, complete bed rest, and proper position of the bed. Bedside area should be above 30 degree above, and tablet aspirolite
To reduce CSF pressure?
CSF pressure.
Okay.
Usually give twice daily, and some BP tablets, mitigation of anti-ulcer, and some advice and some potassium supplement.
Yes.
And some advice to not bending, to avoid squeezing, to avoid nose blowing, avoid constipation,
Okay. Stool softener. Okay. So, thank you.
also avoid seated breathing, which causes
What?
avoid patient has to avoid seated.
Okay. Do you like to, Pandit, do you like to add any antibiotic?
So prophylactic antibiotic can be used to prevent the incumbent meningitis.
Can be given, particularly in trauma cases. Particularly in trauma cases. Okay. So, a 22-year-old young man, Professor Ashraf sir, attended to emergency department with history of road traffic accident 2 hours back. There was flow of clear water in nasal discharge from left side. Seen by urinating accident and advised hospitalization emergency department, and he advised CSF leak repair. This is the patient, and this is, you have done CT scan, and you have found that there is break in the posterior cabin of the sphenoid, frontal sphenoid. So, what is your comment, or how will you first handle the case?
Thank you. First of all, for conservative treatment, the patient is to be lied on, as Wahid already mentioned, 15 to 30 degree elevated bed rest, and at least for 7 to 10 days. wait for 7 to 10 days, then do another CT scan, whether the leak is there or the patient's symptoms. But first of all, conservative management, not jumping on the surgery. So conservative treatment is the prior in my opinion.
So,
Active with the other medical treatment.
okay, so all panelists, Dr. Shubrod has already mentioned, Dr. Wahi, sir, do you want to add anything?
We are also doing conservative management in these cases because sometimes we have seen that within 2 to 4 weeks the CSF leakage stops, for example.
Okay.
And proper use of antibiotics is very important to prevent the intermittent infections.
Okay. So, trauma cases, any accidental trauma, usually improves by conservative treatment.
But here I want to add another point.
Sir.
There are so many that meta-analysis that if the leak is more than 3 centimeters, size of the leak is 3 centimeters, and on the posterior table, then definitely they have advised for neurosurgical intervention. Because more than 3 centimeter usually does not deal with the conservative treatment.
Okay. Centimeters, not millimeters. Okay, defect is more than 3 centimeters, not 3 millimeters. Bony defect. A 42-year-old young man, history of hospitalization 5 times during last 8 years, with high fever, severe headache, vomiting, disorientation, and lumbar puncture and CSF studies shows turbid CSF with high cell count predominantly neutrophilia. This is the patient, and on examination you have found a scar mark on the forehead. Gross examination and he has history of road traffic accident. This is CT scan. On CT scan, we see the defect in the anterior fovea. Anterior fovea, bony defect in the anterior fovea. So, Professor Dipankar, what is your opinion? How you want to proceed?
Micro leakage in the area due to traffic accident or other accident. So we in this case we are doing investigation like CT, MRI.
It is already done.
CT already done. MRI. And in this case we need surgical intervention.
Okay. Any other opinions?
Proper antibiotic treatment first.
Okay.
High state antibiotics to prevent the intermittent infections, and then I think surgery will be the approach.
Okay. Sir, Ashok sir, please.
Because high fever, here is one, the symptom is the high fever.
Not sir. 5 times he has suffered from this.
That is a recurrent case.
Recurrent.
Once the fever, with the fever, one should not proceed with the surgical intervention.
Now he is appropriate. Now he is appropriate.
Then definitely go for the medical treatment, then the conservative treatment if it fails under your direct supervision. The patient may lead the bizarre history. So if you admit the patient, then you are under supervision. If the patient does not improve with the 7 days conservative treatment, go for
Now
the
sir, now there is no fever. He is already, he is alright now.
then straight cut to surgery.
Okay, sir. Because he has suffered 5 times from meningitis. We don't like another meningitis, another attack of meningitis. So there is definite history of trauma, and there is definite finding in the CT scan. So there may be micro leakage. So in case of micro leakage, MRI may not give any findings. In case of micro leakage, we can directly go for surgery, sir. Dr. Shaurav, a 33-year-old lady with obesity, morbid obesity, there is no cause, but there is CSF leakage. what may be the cause?
Because there is an old lady, woman, and obesity.
33-year-old.
33-year-old. Idiopathic CSF, there is no other cause finding.
Okay.
Then it may be idiopathic intracranial hypertension or benign intracranial hypertension.
Okay, maybe.
The cause, sir.
So for confirmation or supporting findings, whether it is benign intracranial hypertension or not, do you want to do any other examination or investigation?
Yes, sir. We want to do other investigation also. At first, we have the proper history and the risk factors, because she is a young lady, and there are other we should do the in that case we should do the vision test, ophthalmoscopy, visual field test, and we also in such a case we can do some neuroimaging and also the lumbar puncture study.
Okay. We have to make it short. Ophthalmoscopy কি পাওয়া যেতে পারে? Papilledema পাওয়া যেতে পারে. Papilledema. Okay, please. Better information.
Better
Yes,
information.
yes.
Empty cell.
Ophthalmic nerve. Yes, there may be. Yes, there may be underneath the optic sheet. There may be
Optic sheet is the correction. Yes, sir.
Correction, yeah.
Extension of the nerve sheath of the optic nerve,
Okay.
and the bulking of the optic nerve head. Ventriculomegaly.
So there may be thinning of the in different parts. There may be thinning of the skull bone. There may be ventriculomegaly, and CFS space may be dilated. So, okay, as there is shortage of time, Dr. Shuro, how will we advance for treatment of this benign intracranial hypertension?
Treatment of the benign intracranial hypertension, that is for the at first dietary lifestyle change, dietary weight loss, and then some medication.
Yes.
Then furosemide, acetazolamide, we can do. Then on surgical approach, we can do some VP shunt and cerebral shunt, repeated lumbar puncture. That we can do.
Okay. So, as there is shortage of time, we want to make it short. Sir, treatment of obesity is very fruitful in treatment of benign intracranial hypertension, and it takes time. So, in the meantime, Dr. Shurab has suggested some acetazolamide or some drugs to lower the CSF pressure. Sometimes conservative treatment works good, but surgical treatment may be ventriculoperitoneal shunt, or maybe even if there is vision is under the thread. In that case, we can decompress the optic nerve and make a opening in the optic sheet to allow some CSF to leak. Benign intracranial hypertension conservative treatment works very well in many cases. Because there is shortage of time, there are many advantages of CSF. Then conservative treatment and surgical treatment. Surgical treatment, we usually do endoscopic management nowadays, and now there are transcranial and intracranial approaches are nowadays not very much practiced. What are the surgical steps? Ashraf sir, please sir.
Actually, the surgery is endonasal endonasal surgery.
Sir.
First, you see the leak, detection of the leakage. Then there are so many other procedures. One is used to do with its own procedures. So, what in my practice, may differ with others.
Sir.
So what I do usually, the ball valve technique. The leak is detected first, then specialization of the leak, then the pressure index like the lining of us. The undersurface and the oversurface. The undersurface, the mucous lining. This lining is to be at least 1 millimeter height. And then from the periosteum, the endosteal layer of the durameter is to be elevated. Or the cap is to be inserted. So after the preparation of the leaf, then that is known as the harvesting. After the harvesting, then the mucosa, what I do, take a fat lobule, that the fat from the lobule. This, I prefer the fat from the lobule because it is very hard and stingy. Then make it a swisher and then put it in the through the leaf. And that is the bathtub technique.
Yes, sir.
That is the bathtub technique. And pull it, that is the either the fecal thing or the catgut or any other thing. Then again the mucosa from the floor of the nose or anywhere, you put the mucosa there over the fat here and then glue. Okay. Only glue. No other technique. And that is my 11 cases.
Okay.
And that is the one.
Thank you, sir. Sir, so because of shortage of time, we have to stop it here. So exposure of the scalpel defect, pressure of the defect, sealing with fascia, fat, cartilage or bone in some cases, hydroxyapatite in some cases, nasal mucosa, carbonate flaps in maybe composite drug, maybe artificial drug. It depends upon the size of the leakage, size of the leakage causes, and then packing materials, maybe surfaces, maybe cell foam, maybe deep pack, and maybe nerosine, many packing materials will be given. It may be underlay or overlay technique. Yes, I have to add. Okay, they are starting the surgery. Okay, last comment is by Dr. Wahid Raizin Sam. So thank you everybody. Now the next session, our live surgery session has already started. So we are waiting for the next session. It will be live surgery. Our renowned next surgeon.